My name is Deborah Kozik. I'm a director with National Medicaid Finance out of the Philly area. I've been with the firm for a year and a half. I'm really happy to finally meet folks in person. And I'm also very excited to introduce our next session, which will be all about health equity. As you all know, the firm has always had in its mission to advance equity. And we've been making a concerted effort to really think about that in the context of how we support our clients and connect the dots with between the Medicaid financing work, the strategic consulting work that we support, and really the health equity focused initiatives that our clients are already pursuing or are thinking about pursuing. So we're going to plan to explore some of the key challenges with this work from a range of perspectives for folks that have been working on these issues for years, and really think about the opportunities we have to move the needle on health equity and what the relative roles are for all of us in that work. So with that, I am excited to introduce our panelists, beginning with Estelle Richmond. Estelle is board chair of Center for Healthcare Strategies. It's a health policy resource center that works primarily focused on Medicaid and improving access and quality for Medicaid beneficiaries. And Estelle is also former secretary for the Pennsylvania Department of Public Welfare, as well as the former COO acting deputy secretary of Housing and Urban Development, or HUD. And she's really, as many of us know, has really spent her career being a champion for health equity issues, really advocating for care for, particularly for Medicaid beneficiaries with complex needs, and looking at it from the perspective of integrating services to support those needs. We also have with us Dr. Abiola Abu Bakar, who joins us from United Healthcare as Director of Health Equity there in Minnesota. She is a trained nurse and doula who supports a number of health equity trainings and strategic planning initiatives with a number of organizations, as well as provides or supports organizations that provide medical care to underserved and uninsured populations, both here and, as I understand, internationally as well. And I didn't mean to skip over Melita Akiti, who is the VP of Ambulatory and Community Health Services at Memorial Health System here in Florida, and oversees primary care and urgent care centers. And she's also the board chair for the Health Foundation of South Florida, whose mission includes driving and advancing health equity, particularly for folks in the South Florida region. And we also have Katie Keith, who's joining us as steering committee member and a co-founder of Out to Enroll, also co-founded by our very own Chris Labonte. And that's a national initiative to support LGBTQ communities and individuals with and connect them with coverage options under the ACA. She's also a former research professor at Georgetown University's Center for Health Insurance Reforms. That's right. All right. And last but not least, Gabe Roberts. I know many of us know him already, but he is the former Medicaid director for TennCare in Tennessee, and has been leading a number of strategic policy initiatives in the state around value-based purchasing, behavioral health coordination, and a number of other key issues. He's also been on the board of the National Association of Medicaid Directors, and we also know him as a senior strategic advisor for us here at Sellers Dorsey.
I began I'm basically a behavioral health person. My background is in mental health, mental retardation, and addictions, and I have been doing something in that field for the last 50, 60 years. So when I got into Philadelphia, after closing the state hospital, my first venture into true heavy-duty management was becoming the Commissioner of Public Health for the city of Philadelphia in 1993. At that point in time, the big discussion was health disparities. And we talked about health disparities a lot. I had staff, we had designated people. We tried to figure out how we were going to get Medicaid recipients, Medicare recipients, people who were dually diagnosed, if you remember those days, and triple diagnosed, all how to get a quality set of health care that they could reach and afford into the system. We looked at the number of people of color that were in our institutions, people of color in our homeless system, people of color in our jails, and tried to understand why we were missing and what we had to do to begin to address health disparities. We put a lot of money into it, we put a lot of staff into it, and tried to see whether or not we were making a difference. And we thought we were. I would say jump ahead probably another 10, 15 years. And we again began to look at it in Philadelphia at this point, and Celis Dorsey has always been around. We were closing hospitals this time as opposed to large state institutions. And the money from that closure, we wanted to plug back into what was North Philadelphia and to try to make a difference again in health disparities. We were trying to be more focused this time. We were looking at an illness-based model, diabetes, chronic heart disease, on how we could reduce those numbers. I think we realized at that point that the amount of money we had plugged in the 90s had made minimal difference, but we thought we still were making a difference, and that health equities needed to be further refined, brought closer down to the ground, focus more on making sure the managed care entities actually saw and were being held accountable for making a difference, and more community-based agencies were involved at that level. And we did much of that. And again, I think we thought we moved the needle. And then the pandemic hit. And it actually, I called it, it was the perfect storm. And I think the one piece that came out of that is all the progress we thought we made actually didn't happen. But clearly, I think those of us who can see in retrospect that the impact that we've made over the last 20 years wasn't really an impact. And as we here begin to discuss health equity, we need to also keep in mind, what did we miss and why did we miss it? It's not that we haven't recognized it's out there. We've recognized the health inequities for the last 30 years. It's not that it hasn't been funded. In many ways, it's been funded over those years. But when the rubber hit the road with a pandemic, we realized that the people with the highest death rate, people who were suffering the most, people who were not being treated, were again people of color and people who were poor and people who had chronic illnesses. So what as a country have we missed, and how can we change that? And the first question that I always have is, what is health equity? My guess is that almost everyone in this room would have a slightly different answer to that question. And from your perspective and from the way you practice and you work in your communities, how do you define health equity?
I will start by saying, yes, I work for United Healthcare in the Medicaid side. I feel like that makes me a little better. Yay, Medicaid. But yeah, so for me, when I think about defining health equity, it's really about intersectionality. We do not live single lives or single issues as well. So intersectionality between health, socio or social status, as well as economics, and how do those all overlay and compound as well. I also am at the space where before the pandemic, very much in a health equity, how are we creating tools that are beneficial for the individual and coming at it from that perspective. And since the pandemic, and very much in a space of health justice. So how do we move from compensating to addressing root causes? But we'll go way more into that. I'll pass it on to you.
I looked at it as a provider. I 30 years now providing services for basically all of the population that you can think that is disadvantaged: correction health, mental health, underinsured, because Medicaid is considered underinsured and uninsured. So that's the population that I've worked with for the last 30 years. And the way I see health equity is the mechanism where each one of us, and it's individual, look at our bias and our ism and be able to identify it at the door and walk in to provide good and the best health care that individual can receive.
Thank you. Katie.
Thank you. No, that's perfect. I would only add, I think, building on the intersectional points that Abiola mentioned, I think, how do we sort of even reframe the health that we provide, even in healthcare settings, to help people with disability, right? We have so many structures that are not even built for people who, and I think about that for trans people, for trans communities. You know, if you don't have a mammogram machine that will drop down to the floor for someone in a wheelchair, you cannot deliver good care. And so there is both sort of the social and societal, when we talk about health equity and we talk about social determinants of health, of what's going on outside the health systems and the coverage, and then even within sort of the operating room, the physician's office, the hospital, how can we be delivering care and getting to, I think, the perfect explanation that Melita just gave.
What I would add is kind of building on what Katie just mentioned. As a former policymaker and regulator, when I hear the phrase health equity, it's a call to action for me. I used to have this saying at TennCare that debate was a sign of respect, and inherent in that was the idea that we all had blind spots. And we all brought our different lenses to the policymaking table. And we needed to make sure that we spoke up if we saw somebody kind of leaving something out or having something that was incomplete. We don't need to understand everything about everyone else's experiences in order to respect them. And I feel like a call to action founded on respect is a pretty good place to start, even if we don't have all the answers right now.
So my question to the group is, what are some of the key challenges and barriers that you believe have kept us from achieving health equity, and what is it that you may see we need to do to actually make that change? And I know from Akita, she has soapbox of all types to talk about, and my guests, so do the rest of you. So let's hear a little bit about what you would do to both meet those challenges and to make that change.
The challenge is that we have a system that is very compartment. It's like mental health, physical health, substance abuse. So the thing here is that you have a system that is broken because you're looking at the individual in pieces. And is that I do not, when a patient comes in, I become payer agnostic. We are the public health system, so we are able to do that. Becoming payer agnostic means I can treat the individual regardless of ability to pay, regardless of, and so when I treat them, my outcomes are better because believe it or not, you spend less money when you treat the whole individual. And so that is one of the big major problem in the system, that this system had silos. And if the system was one because an individual is one, then you will be able to deal with them.
So I will say, coming from a provider perspective and now on the payer side of things, to your same point, collaboration and this lack of abundance is one of the key challenges. I think in Ohio, we're seeing really great things where Ohio Department of Health is, or Department of Human Services, saying all of the MCOs in the state have to come together and they have a shared community investment pool that's focused on health equity. They pool their dollars and they do that work in unison because it is work that should be done in unison. So how do we get rid of this competition and get more into a collaborative space?
I think one thing that I've been thinking about, and I think it was sort of what can you do to sort of address this at your organizations, you know, working with LGBTQ populations, that's a population that has been like healthcare is not a safe place for queer people. We actually have to do additional messaging to that population to make sure they know they are protected from discrimination. And that, you know, sort of like culturally competent messaging is one thing. And of course, that's very much the bare minimum and the start, but that's one example of sort of how you have to bring people in. It has to be so intentional. It has to be so focused. It has to be community-based. I think very consistent with what you all are saying.
And then I'll mention one of kind of the elephants in the room from a policy standpoint is that Medicaid oftentimes pretty political at the state level. Some places health equity is a pretty charged phrase that might get the door closed on you immediately. And so how do you pivot quickly and get the same goal and the same outcome, the same policy, but wrap it in a narrative that isn't manipulative, but that is compelling and is, again, a call to action? And so how do you come alongside your team or us with our clients and help them craft those narratives that can kind of help them figure out the landscape and the narratives that ultimately result in policies that really are promoting a reduction in disparities across individuals, policies that are trying to achieve health equity across populations in your state. I think that's extremely important, and I think it's a practical challenge that a lot of regulators face often.
I don't think anyone at this point or probably here would make an argument that our system isn't still broken. The question is now, how do we begin to take the steps to fix it? And part of that also, I think, is gets entwined with who are our partners, because none of us are going to fix a system like the U.S. health system alone. It's going to take not only some partners, it's going to take a lot of partnership. And I would ask all of you, and Gabe, let's start with you. What are some of the strategic partnerships, or what do you believe are some of the partnerships that are really going to be necessary if we're going to move this needle towards correcting many of the things that I think we've begun to address as part of the problem?
I think Sellers Dorsey is uniquely positioned to really be able to help drive this conversation and really help drive, more importantly, actual progress. You work with state leaders from a policy standpoint, perhaps, for example, to help them reprocure or redraft MCO contracts. And what are the performance improvement plans or projects? What are the quality withholds look like? What do the provider network requirements look like? What do the cultural competency standards look like? I think those are really important opportunities to really be on the ground floor. When you're working with hospitals, safety net hospitals, or other types of providers, how do you work with them not only to respond and anticipate policy changes or directions at state and national level, but how do you help them address some of the points that we've heard really well from our panelists about what does the policy ultimately look like from the state when it's translated to the provider and the member interaction. And I think Sellers Dorsey has a really unique opportunity to help kind of drive that and take lessons learned from different markets and from national kind of perspectives to do that. A couple of other things that I would mention that I'm personally really proud to be associated with a firm of is that there's been a commitment at the highest level to create a segment of the firm focused on health equity initiatives, helping us be able not only to define what kind of we think the current problem is currently, but where we think it's going to go. And I think the work that they're doing, not only with clients, but also at the firm level, to be able to infuse kind of an ethos to say, look, in every project that you all are working on around the country, push for the right questions to be asked and push for the right type of policy to be there to be addressed when it's welcome, and sometimes ask the hard questions when perhaps it's not being discussed. What can we do to make this policy incrementally better to actually achieve the outcomes that we've been talking about? One of the most impactful opportunities for us kind of pivoting quickly and helping move system large, like writ large movement is around directed payment and financing models. When you're working with states and when you're working with CMS to approve these, money can't do everything, but it can help on a lot of things. And if you can craft certain policy initiatives and certain outcomes and certain purposes for certain types of supplemental payments to providers who are really serving a disproportionately large number of Medicaid recipients and or a disproportionately large number of members of populations and demographics that have historically been marginalized, then I think you can do a lot there. Not only does that help deliver more funds and tie them more concretely from a policy standpoint at the state and federal level to actually achieving health, doing better or progressing on health. I don't know if we're going to achieve it, but at least progressing on the continuum of better health equity across all populations. But it also is a proactive defensive step if there is any concern at the higher levels of national government around continuing to approve these types of payments.
I'm a lawyer by training. I don't know if that was in my bio. I think in addition to this is the right thing to do. This will get good outcomes. This will bring more money in the door. I think as consultants and as advisors to states designing their programs and to other plans, there's some legal requirements that Sellers Dorsey could lean in on. I'm thinking of Section 1557 of the Affordable Care Act. I'm thinking of Title VI of the Civil Rights Act, which desegregate, combined with Medicare, desegregated hospitals in the South. I think you all as sort of trusted advisor, when we say it, it becomes an advocacy issue. It becomes very political. You all are in those rooms though, and I think have this role to say, it's the right thing to do. It's good for outcomes. It brings in money. And hey, maybe you want to check out this requirement. Here's another really good reason to do this to comply with, I don't know, federal civil rights law.
You guys are, Senator Durst in a good position where you come in as an expert and everyone listen to the expert. And so you have an even stronger mandate to be able to be that voice, say what needs to be said, because you are consultants and you are the expert. And that is expectation that those that hire you are requiring from you.
One of my biggest concerns, and probably where Sellers Dorsey had such great influence, was working within the hospital system and trying to help, I think, with state policy on how you balance in a large state like Pennsylvania, where you have two large metropolitan areas and a very vast area of where you had small safety net hospitals, where you might have one hospital per county, serving a fairly large population that struggled. Plus, you had your safety net hospitals in your large cities. And you had to create that difference on how to get those safety net hospitals to survive. And it could be a day-to-day battle. And at the same time, so much of the lobbying money was in those very large hospitals. So how do we make sure that our safety net hospitals, who are so critical to the survival of communities, have the resources to survive?
That's a very powerful question, because a couple years ago, a group of sickle cell warriors walked into the Board of Commissioners meeting and said, "We are not being treated correctly in your properly in your emergency room." And we all know that sickle cell affects Blacks and Hispanics, and the majority are Medicaid. At that time, and we are one of the fourth largest public health system in the United States. And at that time, everyone looked at each other and and we kind of created a little program for a $2.6 billion organization. I said, we created a little program, but I said, enough is enough. We need to do the right thing. And now we have a medical home for the sickle cell. And by the way, Florida is one of the highest sickle cell diagnosed individuals are in Florida due to our proximity to the Caribbean, our Hispanic and Black population. And if you ask me about Medicaid reimbursement for those programs, it's non-existent. But because we're doing the right thing, and like I said, we looked at it and we said, enough is enough. So yes, as a public entity, we are the safety net.
Yeah, I will share that when we think about safety net hospitals and how to support them, and coming from the MCO space right now, would really be, once again, going back to this space of funding, and how do you use funding that is interactive and integrative, and how do you use funding in a way that's not dictating what should be done, but responding to needs. And that's really this idea of like, how do we push MCOs to pool funding to be used by community partners like safety net hospitals in ways that they decide? Once again, not a new concept. Ask people what they need, let them set the terms. But what does that look like when they are a stakeholder in your funding decisions?
Yeah, I would only add, I think the commercial market plays a huge role here as well. And so, there's things like there's a proposal by the Biden administration right now. I have focused much more on the commercial market and sort of the individual market, but you think about all the churn and sort of treating the whole person as people move between systems. How are we actually treating them and giving them as an individual the healthcare that they need? So one of the proposals that they're doing is, requiring the commercial plans do better in their networks about contracting with essential community providers, which certainly safety net hospitals are there, but we need FQHCs, we need community health centers, we need Ryan White planning, Ryan White clinics. We need some, it should not be that these sort of safety net providers writ large, a little bit less directly on hospitals, but that are sort of, again, kind of left out of the care that we're giving for folks. And community health centers, the data is so compelling, been heroes on COVID response and vaccination efforts and getting shots in arms to people who need them. And we're sort of just waking up to that. I do think from the federal level, there's this recognition. And so I think some of those requirements from the commercial side too, of getting actual reimbursement, making it better for people to get the care where they normally go and not disrupting there either, is also really important. So would broaden that out in terms of, who's responsible for also keeping safety net hospitals and maintaining access.
It's amazing to me. We've done most of this conversation, and we haven't brought up one of the other terms. So I think I saw it lightly, of the social determinants of health, which happens to be my soapbox these days, and that health care is actually not first on people's list when they talk about what's important to them personally. Pretty high up there. The two things that I preach these days, and unless you get them under control, you won't get to health care, are housing and food. If people are not in stable housing and they don't have stable ways of getting food, healthcare is not what's going to pop up unless they're so sick that it's not longer a choice. I really want, before we close with each of you having a statement, let's hear a little bit from you around anything you've heard, ways that we can be more precise in terms of answering what you do on a daily basis and how we can help.
Hi, I'm a board member, so I didn't get access to the app. But I'm Bill Lucia. I have it's a little controversial of a question. Do you think it's important to have more white men speaking out about this? Because, I went to the health conference last year. Most of the speakers were not white men who were talking about health equity. And clearly my experience is different. But when I read that Black women are 3 times more likely to die during pregnancy or postpartum than white women, it just infuriates me. And so the work that I've been trying to do with the companies that I advise is around this. But do you think that would do something to have more white men outspoken about this? And I'm not saying that white men have a better story, but would it help?
In my experience, what I think works best is not even breaking it down by race, but looking at functional areas. I want people in finance talking about it. I want people from an operations standpoint. I also want people from a clinical standpoint. And then when we get into race, because it is important in this context, we need to see it across the board because we all have different social capacity and social capital, and how you leverage that is power. So it is always important to have a variety of people talking about it. And I think that's the big piece, is how do you get everyone to lean into this? Because I said this earlier in the week, just by virtue of being here and working in Medicaid, surprise, you're already a health equity advocate and champion, whether you like it or not. So how do you lean into that and really own that space?
I guess I will, what your question made me think, I will not answer your question directly, I guess. I do this work for Out to Enroll, doing LGBTQ health work as an ally. I'm a straight cisgender woman. I just think the issues are really, really important to me. And I remember learning about transgender health insurance exclusions. And I had been in private health insurance for a long time. And I remember coming across that and thinking, I could not think of anything more discriminatory than, like, you don't get the same type of care that everybody else gets because of your gender identity. And I was outraged, and it has taken me on a career path that I never would have expected. That said, I'm an ally. I'm not a member of the community. I have found that in some rooms, I can be much more effective than someone. I can do some really good trainings, and I can speak passionately about, even as an ally is not someone affected, why I care about this, almost to, channeling your rage about maternal health disparities. But there's also going to be rooms where I'm not the right person to be representing the organization or speaking. And that tends to be, in those cases, I would put Chris on the stage to talk to, his peers and fellow community members. And we would do that at LGBTQ churches and community centers and all these different places. And so I think it has to come from that education. And even personally, it took me a long time. So I felt confident like I could be a good representative of the issue. But I think you have to sort of build up, that knowledge base, that comfort level so that you're going to do right by the issues that you're talking about, which seems like an obvious thing to say, but I feel the need to say it. So it's a little bit of a different issue, but I think allies can be extraordinarily helpful as long as you're sort of centering the right things in your work.
So I think there's actually a couple questions with the same theme with regard to, we've been talking a lot about the challenges and what makes this work so complex, but the question's really around where we're seeing progress and how we can build on that progress. And so thinking about the narrow door policies and how do we widen that door?
We spoke about postpartum, and I was extremely happy when the state of Florida expanded the postpartum to 12 months. Now, policy-wise, wonderful. Implementation, operationalize it. How many women are able to get appointment with their Medicaid OBGYN? How many actually know that there's an extension? So policy is great, and I was excited. So the thing here is that we have to now, how to operationalize that policy, how to make it a reality, how to actually give access. How can the provider have access? So we have done a great job. I'm just giving one example, but we need to go beyond, and we have to actually look at it from the perspective of how can this become a reality?